Welcome.
Thank you. Chairperson Hansen and committee members of the Health and Human Services Committee. My name is Jean Amoura, Jean Amoura, and I live in Omaha. Thank you for allowing me to express my opposition to LB 574 today. I work at Nebraska Medicine, but my statement today is mine alone. I'm board certified in obstetrics and gynecology. I was born in Nebraska, I studied here, and I've been practicing medicine here for over 20 years. While my original specialty training did not include management of transgender care, I recognize this as a significant unmet need just a few years into my practice. I sought out the additional training from experts around the country and connected with therapists locally who had experience in providing gender-affirming care. I continue to follow expert guidance and new research in this field, as with every other aspect of my medical practice. I work with many families from across the state who are seeking help for their children. They've been parents from cities and small towns with no background in gender identities or LGBT activism, but they were present as their child developed, and they witnessed the distress and despair their child experienced when the world around them didn't see them as they saw themselves. These are parents who knew the truth of their child, that this wasn't messaging coming from YouTube or TikTok, but a deep understanding that this child had of themselves. They knew that they must find a way to protect their child and allow them to reach their greatest potential. These parents are not experts in gender theory. They are simply experts in their own child. They sought input from clinicians and chose pathways they believed would help their child survive and thrive, just as any of us as parents would. I've worked with dozens of families of teens seeking gender-affirming care. They're referred from across Nebraska by their family doctor or pediatrician or therapist after lengthy conversations and careful evaluation. I continue these conversations and support the families in their medical decisions. I've witnessed many young people emerge from a state of isolation and fear to enjoying a life where they can safely and confidently attend school, make friends, play in band, and plan for college. My experience is not unusual. There is robust evidence that transgender youth do well when they are supported. Legislative Bill 574 would harm our communities and our children by removing life-saving treatment options from parents as they stand up for their children. It would force doctors and other healthcare providers to conceal and withhold treatment from young people that American Academy of Pediatrics and the many other organizations you've heard already endorse as well within the boundaries of standard care. And it would create clinical practice where lawmakers can overrun the fine-tuned judgment of cautious and thoughtful clinicians who have committed to do no harm. I ask you not to advance this bill.
All right. Thank you for your testimony.
Thank
Are there
you.
any questions from the committee? Yes, Senator Day.
Thank you, Chairman Hansen, and thank you, Dr. Amoura, for your testimony. So you mentioned getting referrals from family doctors.
Mhm.
What is the typical process in which families will come to you? Like, what does that look like?
So virtually always for young people, they are referred by mental health provider or primary care provider. So it might be a family medicine or a pediatrician. When they are referred, before any appointment or anything is made with me, we first require that we have received written support, a letter from their primary mental health provider. And if they have not started to see a mental health provider, we make sure that they find a mental health provider, work with that person to discuss their gender dysphoria specifically, so that we can have written documentation that they have worked with a qualified mental health provider and that person's made an assessment. Once we've received that, then they, in the system that we have with my employer is, in my clinic, is that they also then are evaluated by a psychologist with expertise in gender dysphoria and adolescence specifically. after they've had that assessment, then the family meets with me, the parents and the young person. And all of this, again, typically happening when they are at the very least already entering puberty is typically when we meet with them, because there's no medical intervention that would be necessary or appropriate before that time.
Okay. Can I ask you? So this bill not only would, as I read it, outlaw any kind of surgical intervention,
Mhm.
it would also create punitive action for anyone providing a referral.
That's my reading of it as well.
Okay, so doctors wouldn't even have the option of referring patients or families to someone who specializes in gender affirming care. Is that what I'm understanding correctly?
That's how I understand it as well. And I think certainly that the mental health providers and the physicians that I know of that are currently, again, across the state and part of the folks who have referred people to me in the past many of them have been in contact with me because of concerns about where they will send future patients. This is a situation and a diagnosis that comes up fairly rarely, which is, part of why there are not many doctors that do this care. And it's important, especially for young people, that it's done with the infrastructure to have a lot of checks and balances and people are very concerned about where they will refer patients when the situation does come up.
So that would be my next question is, if this were to pass, what would be the options for parents of children who are experiencing gender dysphoria?
I believe that they would need to seek care outside of the state.
But they couldn't be referred to someone outside of the state.
That is also my understanding.
Okay.
Mhm.
Thank you.
Any other questions? Yes, Senator Kavanaugh.
Thank you, Dr. Amoura.
Mm-hmm.
So it was passed out, I think, more than once, a form that has your name on it. So I'm assuming it's from your office, Specialty Care Center. And it looks like it's an intake form. And since it has your name on it and it's been brought to our attention a couple of times, I wondered if you could give us not a brief overview of what the starting of this process looks like when somebody comes to you. Why did they fill out this form, and then what are the next steps?
Yeah, absolutely. Now, and this is a big part of why I wanted to be here today, to frankly be very transparent about the process in our clinic. I've been very careful in starting doing this work to do it with great care, and it's been a slow and very deliberate process. Similarly, I'm very transparent when we're talking with parents or families who are interested in speaking with us, having an appointment with me, so that we can give them information like this on the website ahead of time to try to alleviate concerns about questions that may come up. We have lots of information on the website. The goal is not that we're informing anyone that they need to see us or take any, accept any treatment. It is that the patients are seeking us out, and we want to be able to provide that experience as just as the least stressful as possible, so that they understand in advance the kinds of questions that we're going to be going over during the first visit. The information, for example, about surgeries that people may be interested in pursuing. Many transgender people are looking at pursuing hormones. Many are not. Some trans people are looking at pursuing surgery. Many are not. It's part of just my comprehensive evaluation of someone to get a sense of what their goals are, what areas of their body are causing them distress or dysphoria, so that I'm fully informed, that I can be discussing with them what the medications that we might be looking at will or will not do, that I can make sure that we're very clear about what the treatment plan is going to accomplish. It's just a part of a comprehensive discussion of risks and benefits, as I would do with any treatment that I provided someone.
Thank you. If you don't mind,
Yep.
follow up. So this is the first time this has been mentioned today. Many of the patients are seeking treatment through hormones or surgery. Many are not. So people are referred to you and they learn about some of these options available to them and they don't take them. Correct?
I mean, that's right. It's not an automatic that, I mean, I would say my statement earlier was just that many trans people
Okay,
want hormones or want surgery, and many do
Don't.
not.
do not.
So it's not.
It's
that
not
an-
it's not a monolith.
Correct,
Okay.
exactly. I would say more often when people are scheduled to see me, they it's not just that they were referred, but they actively want to be seen in the gender clinic. It is because they already have expressed that they want to start on hormones. I don't do any surgeries, just as an aside, but they've already expressed that they want to start on hormones, or that they just want more information. And plenty of people come in and decide that they don't want this or don't want it right now. Yeah, so it's not like it's,
Sure.
I mean, these are, as with any kind of medical care, there's a case-by-case decision-making that you're trying to tailor to what are the needs. Is this person ready and appropriate to take this next step? So trying to get as many sort of points of input as possible as we go along, monitoring after we start, if they do decide to start on hormones, to monitor the physiologic effects, but also the emotional effects. And it's a pretty close contact that I'm maintaining, particularly with young people.
Thank you.
Mhm.
Yes, Senator Rigby.
Thank you, Chairman Hanson. Like my colleague to my left, I too have your intake form, I believe it is.
Yes. Mhm.
It says on this form, it says 13 to 18 years
Mhm.
form. I assume that that's that category. And yet, my question would be is, I see no parental signature on here for underage that says, to keep the parents involved.
Right.
It seems like a very critical missing piece because these children are children and they're
Yes.
underage. They're not legal
Absolutely.
adults. They're not emancipated.
Absolutely. No, make no mistake, the parents or guardians are involved in every step of the way in my clinic.
But you would know it by looking
They-
at the form.
The form is sent actually to the parents. It's available on the website, so anyone could look at it. But as far as making an appointment in the clinic, that's only going to happen through a parent. The involvement with the assessment that's done by the psychologist that's on my team must involve parents at that assessment. And the visits with me always involve parents.
Who do you assume is going to fill out the form? The 15-year-old or the parent?
Potentially, I mean, I honestly would welcome a 15-year-old to fill it out, because what's going to happen is that when we are actually meeting for a clinical visit, I'm going to have this in my hands and I'm going to be going over what whoever filled out the form, what they had listed.
If I had a 15-year-old and filled out the form, I, as the guardian or the parent, I want to see what they put on there so that I can say, I need to
Right.
maintain my relationship with my 15-year-old.
Absolutely. So again, someone could access this just simply by looking on the internet. If they are, however, actually engaging with our clinic, seeking an appointment, et cetera, all of the communication is with the parent or guardian. An electronic file with this document, we're not, asking people to go look on the internet for it. An electronic file of this document and the consent form, which you don't have, but we also do have a consent form specifically for gender-affirming hormone therapy. Those two electronic files are sent to the parent who's responsible and who's been in contact with us about making the appointment.
I have one follow-up question, Mr. Chairman. I'm just looking at, what's the level of activity in your practice? How many, I'll call them patients, clients, how many do you have in, say, a year's time or 6 months?
Yeah.
I mean,
Probably in a 6-month span, probably a couple hundred.
okay.
Mhm.
And some of those, I suppose, are curiosity or not yet made a decision. So you're there to help make that decision.
That's exactly right.
Okay, thank you. Thank you for being here.
Thank you.
Thank you for sharing.
I just wanted to add on the consent form, because you'd asked about, there was no place for the parents to sign on this. And again, this is just used as an intake. The consent form that's required to start treatment. So this is kind of just for me to start a conversation when they come in for the visit. That conversation includes the parents and the young person and myself.
Okay.
The consent form must be signed by the young person and the parent and myself. And
I don't, excuse me.
Yeah.
I don't disparage young people, but they have been known to forge their parents' signatures on school reports and a bunch of other things. So that could all happen. Okay, thank you.
Any other questions from the committee? I think you answered my questions. Mine was the biggest one, had to do with consent.
Yeah.
Right? And the parental involvement with consent, or consent to treat,
yes.
And same thing when you do start treatment, you have parental consent. Is there any kind of steps you take before that?
Right. So there's a consent to treat that we just have generally kind of for all care in the hospital. So that's of course required as a baseline, but specific to what happens is that usually before we even make the appointment, we send that out so that families can review the information, the intake, and the consent form so that they have some sense of what we'll be talking about. We have the actual visit, answer whatever questions come up at that time, and then they are informed that if and when they want to start hormones for the young person, that the consent form will need to be signed and submitted. And they are encouraged to not sign and send it in until all of their questions and concerns have been asked. If that means another visit, then that's completely appropriate. But they've had the chance already to preview that consent form. But yeah, when I'm starting someone on affirming hormone therapy, they are completing a separate specific consent form that details all of the points that we go over in the visit about what are the effects of the medications, how we monitor, what are, all of the things that they should expect.
Okay.
There's a separate consent.
With some of your patients, have you experienced any side effects from treatment?
Sometimes. Mm-hmm.
What are they?
I would say that the most common one is probably in folks. One person earlier brought up the medication spironolactone that we use as a testosterone blocker for people that are seeking feminizing hormone therapy. It is absolutely considered part of the standard treatment. It's a first-line treatment that I use as well, but it's the one that I feel like I have to caution patients the most on, that it's a diuretic. One thing, sorry, just as an aside, these meds are all quite inexpensive. They're quite old. This is not like a case of, big pharma and people making a lot of money on these meds. They're all actually, they've been around for a long time. Spironolactone is a diuretic. So it's removing quite a bit of water out of the body, and it used to be used as a blood pressure medication. But we don't use it for that anymore because we've got more advanced things for that. But you give something that could be used as a blood pressure medication to a healthy young person, they don't need their blood pressure dropped. So I'm having to counsel them about beware that you can kind of get a little bit orthostatic or just kind of a little bit dizzy going from laying down to standing up and that sort of thing. Drink lots of extra water. So they're like nuisance sort of side effects, but that's one of the big ones that I counsel folks about.
Okay.
Mhm.
Have you ever counseled anyone against doing gender reaffirming care? Like you come in, you don't think they're a good candidate for it, and you're just like, I think you should see somebody else.
Yeah,
or I don't
I
think
mean-
this is right for you.
Sorry to interrupt. Yes. I would say, the things that I am looking for, asking about, and really carefully listening for when they're in that, particularly in that first meeting with me, is do I believe that they have a clear understanding of what the medications are going to do? And is that what they are seeking, et cetera? So I might have someone who comes in and says that they want to experience changes in their voice. They want to have more, they want to masculinize in the sense of having their voice lower. And testosterone is going to do that. But they express some concern about developing facial hair. And testosterone is going to do that. And so I'm going to look at that person to say, this is not going to be an appropriate medication for you.
Okay. And this could be a 13-year-old, potentially? I'm looking at your form, it says 13 to 18-year-olds. So a 13-year-old, you do this too?
Well, usually for affirming hormones, so these are the intakes when people come in. So I do see people that are from the starting point of puberty forward is when I might see someone. That's not necessarily when I would start them on affirming hormones if that's what they wanted. That we tend to try to correlate with having peer concordant puberty so that they're entering puberty around the same age as their peer group rather than waiting until 18 or 16, et cetera. So
I don't mean to ask a lot of questions.
Yeah.
These are questions I get from people, and I'm trying to make sure they get answers so people kind of understand how the process works. Also, for my
Honestly,
own curiosity.
I welcome it.
And so if I can ask maybe a couple more real quick. Sorry,
Please.
I don't want to take up people's time either. So
So
but-
do I treat people that are 13 to 18 with affirming hormones? Potentially, yes.
do you know off the top of your head the youngest
Mm-hmm.
patient you've had in your office that you treated?
I mean, so the youngest person that I've seen is probably 8. They didn't need medical treatment. The family and that child needed a consultation because they had disclosed their gender identity since they could speak, similar to the story, the parent that we heard earlier. That's not at all uncommon, and that folks will say, we've been raising our child all in agreement, and the school does not know what their sex assigned at birth was, and they get to be 8, 9, and they start to get very anxious about what is going to happen when my body starts to change in ways that are completely different than how I'm living, how I identify, how everybody knows me. The child that is assigned male at birth has been identifying as female since they could speak, and has gone to school, has had maybe the parents have changed their name. I mean, there's no one in their world outside of their immediate family that knows their sex assigned at birth. So it's critical that they start, you can imagine they start to panic as they get to foresee puberty and imagine that their voice is going to change, their hair, facial hair is going to, so a lot of times those folks will come in fairly young, just so that they can kind of understand what could the landscape look like for us? So I see people that young, I don't treat them. I treat folks if they are seeking treatment. The earliest they would need medical treatment is when puberty starts.
Okay. And one more quick question. Sorry. I didn't catch the name of the clinic you work at.
Nebraska Medicine.
Okay. I was just kind of curious about that.
Mhm.
Any other questions from the committee? Seeing none. Thank you.
Thank you.